Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach. And this is Dadvice TV Live, coming to you at the very end of August on a wonderful, at least here outside of Detroit, Michigan, wonderful Friday evening. Now, tonight, we've got a great topic. We're going to talk about dialysis. And Dr. Rowe, my co-host, the expert here to talk about it, mentioned this is going to be a hard-hitting discussion tonight. Now, we also are going to try something new. While Dr. Rowe and I are on the screen in just a few moments, you guys are going to see beside me this ranking, and it's going to say top fans. And those of you who are watching on the live session on YouTube, every time you make a comment or share a sticker or things like that, YouTube gives you points and you can work your way up the ranking list to the top of the top fans list. And as people comment, like our good old regular Wisconsin grandma there I see in the chat, you're going to move up the rankings. And I can't wait to see at the end who hits number one and who holds on to the number one place. Now let's go ahead. We're going to bring in my co-host. You guys know him. You love him. He is full of so much information, and he is the author of what I think is the best kidney book out there. And in my opinion, when you're diagnosed with kidney disease, if they would just hand the patient this book and say, hey, don't panic. Read this book. It tells you what you need to worry about, what you need to focus on, and what you don't need to worry about. It would make being a kidney patient so much better. That book is called Learn. Oh, oops. I got a button here and I hit it the wrong one. The book is called Learn the Facts About Kidney Disease. There it is. Available on Amazon. It's also an audiobook if you just want to sit back and listen to it. Now, the best thing about this book is it is so easy to understand. You're not going to get worried and find, oh my goodness, I need a thesaurus. Super easy to understand. Now, let me go ahead and bring on Dr. Rowe. Hey, Dr. Rowe, how you doing?
I'm good, James. Good, James. Wonderful to see you. Wonderful to be on your show as always. And I appreciate the opportunity, and I appreciate all the folks that watch the show. And I hope that we can deliver some very, very important information, especially for those folks that have heard the big D word, the dialysis word. It's very scary. And I have some real important information for you folks. James likes me to tell you who I am, what my background is, because not everybody has necessarily seen his show. There's some first-time viewers. I hope there's a lot of you folks. But I am a retired kidney specialist. I've taken care of kidney patients and internal medicine patients for over 40 years. I have not only done a lot of clinical work, but I've done a lot of research work. I have about 100 referee publications. And a lot of my work towards the end of my career had to do with when to start dialysis. And I'm considered basically one of the world's experts on the topic. I've done a lot of deep digging, and you're going to hopefully benefit from some of the work that I've done. And we'll talk about it in detail tonight. And James, whenever you're ready, we'll start. And I guess you'd like me to kind of hit it because we want to have time for questions.
Yep. So everyone who's watching, Dr. Rowe tries to leave plenty of time at the end, as much as we can, to get to your questions. So if you have questions, go ahead and add those in the comments. That'll also get you ranking up higher over here on the top fans thing. Look at that. Lisa Baxter's up there at number one. All right, Lisa, great to see you back. Lisa has a great channel on YouTube. She is an expert too when it comes to dialysis.
Very cool, very cool. So let's just start out with some of the basics, and you'll figure out why I'm starting out with this in just a second. And James doesn't want me to quiz him too much, but there are certain things that we go through, many times. The commonest cause of death, James, in people that have so-called CKD, chronic kidney disease, one of the stages of kidney disease, is what, James? You know that, right?
Heart failure, correct?
cardiovascular disease,
Yep.
heart types of heart disease, heart attacks, strokes, heart failure. And for most of you, the vast majority of you, that EGFR that worries you so much, it is simply a risk factor for having cardiovascular disease. Now, especially for older folks, you're much more likely, this is a very important point, you're much more likely, even if you've been told you have CKD, even CKD stage 4, which is 15 to 30 GFR.
Mm-hmm.
Certainly stage 3, which we'll get to in a minute, you're much more likely to die, not of kidney disease, but of something related to the heart, atherosclerotic cardiovascular disease or heart disease. And even if you have a EGFR 45 to 60, that has been recently determined through the research that you don't even have the higher risk of having cardiovascular disease. So 45 to 60, and I will credit my Australia folks, the Australia colleagues, they do not consider you to have CKD if you're in the 45 to 60 range or higher and you don't have significant protein. So let's get that out of the way, because far too many people, especially older folks, are being diagnosed with kidney disease, being put on dialysis early, which I think is a tragedy. It's a major tragedy. And I think our folks in Australia, part of the deal is that they have socialized medicine. We don't have that in this country. You have socialized medicine in the UK. And interestingly, what I'm talking about today is starting dialysis early and, in my opinion, unnecessarily, is much less common if you happen to live in Australia, New Zealand, or in the UK. So you can consider yourselves lucky in that way. And a lot of folks think that, I'm in a country with socialized medicine and I'm not getting stuff. Well, in some cases, getting stuff may not necessarily be good for you. And you folks that are CKD3 and you're in your 80s and late 70s, 80s, there's evidence that you can be stable for 10 years or more. Why? Because your kidney decline, your kidney function decline is slower than younger folks, primarily because younger folks tend to have more protein in the urine. Mm-hmm. And the protein in the urine is a big predictor of how fast your kidney function is going to decline. And this has been well established. Too many older folks are winding up on dialysis early. What do I mean by early? I mean over 10 in your EGFR number, and in many cases, even over 15, which I think is just really, really bad. Bad news. And one of my papers that from one of my colleagues, talked about a nursing home population where 20% of these people were starting over 15 without any good reason, primarily because of that EGFR number. And that is totally, in my opinion, unacceptable. And the research of a lot of my colleagues across the world have shown that early start, over 10, over 15, may be harmful. But because dialysis is a business and it's a lot easier to manage people, especially as your kidney function gets worse, put you on a kidney machine. The docs can see you once a week. The nurses and the technicians see you 3 times a week. It's a no-brainer. It's much easier to manage. But you should not start it unless you really need to start it. And another problem, so people over 75, the fastest growing population on dialysis are these older folks. I happen to be 78, so I'm in that category. About 1 in 3 new patients are over 75. And I was telling James, I got a paper from one of my very respected colleagues about something called conservative management or palliative care dialysis. We need a lot more folks that are willing to participate in that kind of thing, because it's really appropriate for many, many older folks. And conservative dialysis is a good choice. We're going to get to that in a little bit. And the reason for that is, even with low levels of kidney function, you may survive longer if you're never started on dialysis than if you start on dialysis, if you're one of these patients that's already had heart attacks or strokes or severe heart failure. If you have lots of that kind of stuff going on, you may well do better without ever being on dialysis. Now, one of the things which is not unreasonable, James, and maybe you thought this too. Yes, right? You've got decreased kidney function. And someone comes up to you and says, "Hey, James, you've got 20% of your kidney function, 10%, 15%. I can offer you dialysis." Wouldn't you think that if you go on dialysis, that's a good thing for you? Wouldn't you think that, James?
Well, the way they pitch it, it's a good thing. But good thing for their budget, not for their profit, not for me.
But most people, without having knowledge that we're going to tell you about tonight, would think, yeah, hey, I got decreased kidney function. That machine's probably going to help me. Right?
Right.
They're very wrong. They're very, very wrong to think that. And it's not unexpected that you would think that. But there, unfortunately, are lots of harms, not necessarily for everybody, but potential harms if you go on that kidney machine. And I've written about this, and my colleagues have written about it. What are some of these harms? There's a long list, and I'm going to go through some of them. One of the things is we worry about our hearts. We worry about the heart attacks. What's a heart attack? Decreased blood flow to the muscle of your heart. Guess what? It's been shown by one of my colleagues, when you're on the machine, the muscle of your heart is not doing so great. Okay, so that's one bad thing. Another bad thing is that your risk of having these bad rhythm things that could potentially be fatal is much higher on the machine. And then another thing that's been shown is when you compare people, let's say, that have 15% of their kidney function who started dialysis versus people who didn't start, much higher risk of sudden death, probably related to arrhythmias. And then the other thing that James already mentioned is quality of life.
Yeah.
Clearly, dialysis affects your quality of life. And what are some of the things that dialysis patients experience? They experience sleep trouble, they experience depression, they experience pain, they experience anxiety, and they experience a high rate of hospitalization. And the lower your quality, there's a measure of it, there's a quality of life score. The lower your score, the more likely you're going to be hospitalized or potentially die. Here's the biggest one that really, really bugs me. It really gets me. The one factor that really has benefits that's been shown over and over again. People have tried to show that dialysis has benefits in all kinds of ways. They have all these fancy dialysis machines with these big things. Those of you who've been on dialysis know about the dialyzers. We have all these fancy dialyzers. We have all these fancy dialysis techniques. And they've tried to show that using these various types of kidney dialysis techniques, they're going to have some kind of particular benefit. Have not been able to show it, no matter what the benefit is that they're looking for. But your own kidney function, over and over, the research shows that it has tremendous benefits. And guess what, James? You already know this, right? When you go on dialysis, what happens to your own, which is called your residual kidney function? What happens to it?
Starts going down.
Exactly. In 6 months, you lose half your kidney function. And that is valuable. Even at tiny amounts of kidney function, it is extremely valuable. It has good correlation with better control of your anemia, better control of your nutrition, better quality of life. Anything you want to look at, it shows benefits. And maybe, and one of the things we're not going to get into tonight, if you need dialysis, there's various types. There's something called peritoneal dialysis, which we'll discuss another time. Maybe you lose that kidney, residual kidney function, which is something that is a benefit. That's why I personally think that if you need to go on dialysis, at least consider going on home peritoneal dialysis. So when they pushed this early start of dialysis, there was a lot of bad conventional wisdoms that were just, and I've got several papers where I kind of blow up these conventional wisdoms, show that they were nonsense. One of the conventional wisdoms is that, you better go on a machine because you're going to lose your kidney function quickly, and it's dangerous. No, not necessarily. That is unusual, especially for older folks. I mean, there are rare occasions where your kidney function crashes, but that's rare. And we're going to get into something at the end of this thing called AKI, where your kidney function, residual kidney function, crashes quickly. And just as a point of information, I got into this idea about who should start dialysis, when you should start dialysis. And I've got colleagues all over the world that are interested in the same topic. And one of my favorite colleagues is in Taiwan. And he published a paper, and he's another SJ I talked to earlier about my grandson, SJ. This is also Dr. SJ. And in Taiwan, they looked at starting that. So our papers, where we looked at people starting dialysis at various levels, over 15, 10 to 15, 5 to 10, less than 5, right? That's that is basically some of the categories of EGFR when people start dialysis. And his paper showed that people who started below, get this, three better than people were starting at 6. I mean, mind-boggling, right? Now, I'm not telling people to wait till you get to 3.3, but we're going at 10, 15, and on average in this country, if you're over 75, it's highly unlikely that you're starting below 10. You're probably starting somewhere between 10 and 15, and in many cases, that's too early. And one of the conventional wisdoms was 6 is dangerous. No. Okay. It can be. If you can't be followed, if you don't have medical insurance, which is a huge problem in the United States, where we do not have universal health care. I mean, unfortunately, James probably knows this. If you have no health insurance, if you get on dialysis, guess what? You've got Medicare coverage, no matter what your age. And that's Medicare covers dialysis as long as you've worked and contributed to Social Security for 2 years or something. You could qualify to get Medicare to pay for your dialysis.
It's our only universal health care.
Yeah. Universal health care. You got it. You absolutely got that right, James. And it's a shame, but that's the reality. But in my opinion, if you can get a doctor who's willing to follow you down below 10, below 5, and you're a compliant patient, there's no rush. Nothing has been shown to push you to go on dialysis. And don't think going on dialysis is necessarily going to make you better. Now, there is such a thing as a honeymoon. A lot of people, when they first start, they think they should feel better, and they do, and maybe their appetite improves. But over the long run, the quality of life issues are certainly not worth starting early. And to me, and to James, and to anybody, if someone comes to you and says, I want you to go on this machine for the rest of your life, okay, for the rest of your life, okay, this is not too much to ask. Doc, what is going on this machine going to do for me? Will I live longer? Will I live better? Will it take care of some of my medical problems that I'm experiencing? Unless your doctor or anyone can say yes to any of those questions, Why are you going on dialysis? And the answer to those questions, generally speaking, is no. And unfortunately, okay, so because of my research, because of other colleagues that have done similar research that showed that in my paper, that was, James has heard this, and a lot of you who listened to me before have heard about my paper it was called voted #1 game changer in the field, which basically said that starting dialysis early, and my definition with my co-authors was over 10 EGFR, may be harmful. And I had very conservative, world-renowned authors, I mean, much, textbook writing authors that were with me on this. And they came around and said, hey, we're going to have to agree with you. So pretty much with the research, people say, don't start dialysis just by your GFR number. It is not a good enough reason. You got to have symptoms that make sense that you're treating, okay?
Or symptoms that you can't manage.
Perfect.
Yeah.
Perfect. Okay. What James is saying, and what I promote big time, is your doc wants you to try you on dialysis. Go to your doc and say, James said that, I got some symptoms. Can we manage these symptoms without the machine? Hello. And there's lots of ways to manage the problems without the machine. For example, you got fluid over the big one, especially if you're not making as much urine. Well, if you push the water pills and you use them correctly, you may be able to delay it with that. You got potassium problems. We got drugs to help bind potassium. The anemia is a no-brainer, easily treated. And James already knows this. A lot of you folks with CKD3, no symptoms. Don't expect them. There are no symptoms. CKD4 maybe starting symptoms. Maybe. I mean, rarely in stage 3, which is 30 to 60. Maybe if you're in the 30 to 40 range, you may have anemia. That's possible. But most of the symptoms don't occur till you get to below 30. Now, and I said this before and I'll say it again. If your doc is pushing you to start dialysis, please read the book, the segment where we talk about the early start, what the pros are, what the cons are, what you should discuss with your doctor, and see why your doctor wants to push you to start. And my opinion, is to try to wait till at least the 5 to 10 range, unless you have an absolute indication to start. And we'll get to those in a minute. And this is between you and your provider, your medical provider. Knowing that if you're an older person and you've already got, heart troubles and other things, there is a section in my book where you can go over this with your doctor. It'll tell you the likelihood of how long you will survive after you start dialysis. And you can decide with your doctor whether it makes sense to start. And if as I said, if you have a lot of health issues, you can't walk, you may actually, and there hasn't been a randomized controlled trial of this, but the literature suggests that you may be better off, live longer without even ever going on a machine. And importantly, if you're an older person and you've already got history of heart failure, or already had a history of a heart attack or a stroke, whatever, please have your wishes known with your doctor. Have an advance directive. What you want to do with what you want your family, your doctor to do if you happen to be in an ICU and you're real sick with heart failure or a heart attack or a stroke. Yes or no, do you want to be put on dialysis? Let your wishes known. And as we discussed, as James wisely suggested, it makes a lot of sense to have a trial of conservative management. Let's try to do this, doc, without going on a machine before you go on a machine. And what are the absolute reasons that dialysis should be considered. There aren't very many, and I mean, I went to medical school in '68 to '72, and back then dialysis was pretty unusual. As a matter of fact, it was 1973 before this deal came up with the Medicare Act. So back in the '70s and even the '80s, when I came to South Carolina, I got to see some really, really sick people that were not getting dialysis. But in those days, we didn't have the drug to treat your anemia, the EPO type drugs. And that was a big one. Once we got the drugs to treat your anemia, people felt a lot better. I mean, I had kids in my training. I did pediatric nephrology. I had these kids that had hemoglobins. The normal is 12 or 13 of like 5. And they managed to survive. The problem is you didn't want to transfuse them because too many transfusions messes up your possibility of getting a kidney transplant. You're going to develop antibodies that will reject a lot of transplants. So what are the reasons that really make sense? If somebody wants you to start dialysis, these are reasons that make sense, but they're pretty unusual. There's something called pericarditis, very rare. It's the covering of your heart can get inflamed. It's called the pericardium, and rare. For sure, dialysis. Some people get bleeding troubles. Again, rare. Can also be treated medically, but reasonable to consider dialysis. You got severe GI trouble, severe. I don't mean just, a little bit of decreased appetite. And there's no other cause. But again, I'm not talking about people that are in the 10 to 15 or over 15. I'm saying when you're in the 5 to 10 range. If you're like 10 to 15 or over 15, these symptoms are unlikely to be related to your level of kidney function. Not impossible, but unlikely. But as you get down to 5 to 10, it makes sense. They certainly may be connected. Severe anorexia, you're just not eating and you're losing weight. Seizures, a no-brainer. No other cause, for sure, you need to start dialysis. A lot of confusion. That could be due to a lot of things, especially in older folks. Hard to sort out somebody who's confused and say, hey, that's related to your level of kidney function. May well not be, but that's a theoretical reason if you're in that 5 to 10 range. And the real common one, which is fluid overload. And so many people start dialysis because they have a weak heart, especially older folks. And some of these people are not getting the right water pill, a diuretic regimen. A lot of times you can give them intravenously, not just orally. And you can use combinations of these things to help get the fluid off. Can't get it off, sometimes it's just the fluid off. So that's a good reason to start. I used to, back in the early days, I had people with 1 or 2 GFRs, or 2 or 3, or, and,
Wow.
and they would have pulmonary edema. Yeah, and, because we didn't have dialysis to offer people. So, there were situations where you'd fill up with fluid, you get pulmonary edema. It's called pulmonary edema, fluid in the lungs. It's rare these days because we have really good diuretics, and most people get on a machine well before they get any of that stuff. And a very common scenario where older folks get started on dialysis is they get into the hospital, they have an episode of heart failure, they can't get rid of the fluid, so they get on a kidney machine, and then they continue on dialysis. Nobody ever looks back. please, if that happens to you, if you had an episode where let's say your EGFR went, let's say, from 20 down to 10 or something, or 5, ask your doc, hey, how do we know that my kidneys haven't recovered? Because there are lots of reasons, and James knows these well.
I'm one of them.
Yeah, where your kidney function can decline temporarily, but then it comes back to where it was. And here's an important thing, which I think James, without having spoken to me, may have done. Now, the research on when to start dialysis, not for the chronic people, not for people who have been followed for years, or, and your EGFR, went from 30 to 20 to 10 and so forth, but people who, went from whatever normal range, or somewhere 30 to 50 down to 10. And there's a lot of reasons this can happen, and James knows them well. You want to tell them some of these reasons why what can cause this to happen?
Dehydration, number one, and I think that's what got me. Was I had no clue where my kidney function was. I was sick for 2 weeks. It came out, everything I ate or drank came out one end or the other. Nothing hung around. And I didn't even want to drink water. And I was drinking Gatorade, luckily, which gave me some electrolytes. But that's the primary thing, is dehydration. That can cause a drop. Some medications can do it.
Exactly. The drugs that we always talk about for people with protein in the urine, that are very beneficial to decrease the protein in the urine. And as a consequence of that decrease of the protein in the urine, it slows the rate of decline. Very important. ACEs and ARBs can do that. The SGLT2 drugs can do that. But at the same time, they can cause a temporary decline in your kidney function. Don't let those things get you started on dialysis, because a lot of those are reversible. The biggest ones are, we all take NSAIDs, we take our Motrims when we have aches and pains. Taking those and then get into a situation like James just described, where you have a GI bug, you're having diarrhea, you're having vomiting, you get dehydrated, you have not kept up with your fluids, you didn't get an IV to take care of those fluids. I mean, it's amazing. Your kidney function can look really terrible, especially if it started out bad. Let's say your CKD4, you're somewhere between 15 and 30. Let's just say, for argument's sake, you're 25. You get something like James just described, easily it could go to 5 to 10 with dehydration, easily.
I was at 8 when I went to the hospital.
Yeah, exactly. Yeah, good example, James. Really good example. Yeah, Art Buchwald was a famous writer, wrote some funny stuff, really funny author. And he actually wrote about his experience, which was, they told him he needed dialysis, but it was just like James. It was wisely. He didn't know that he was wise. And I think they took care of his acute renal failure. And the latest research, there's not as much research, as harder to study, about starting chronic dialysis as there is for people starting with AKI, which is like one of the situations that James had. But the research shows, this is recent work, that it may be beneficial, because you never ever on dialysis. I don't know, James, did you actually go on a machine, or did you say
no,
you wanted
they
to
wanted to do it in my neck as an emergency dialysis, because it was probably like the second day I was in there, and they said, you're not getting any better. And I I refused. I said, well, how long does this happen? I've got to travel next week. I'm doing training and I'm going to be very up and around, and I jump around in front of the group when I do training. I'm very animated. And like, oh no, this is forever until you get a transplant. And I said, well, when do I get a transplant? Thinking they're like in the back room or something. Like, oh, it's probably 5 to 10 years to get one. And I was like, whoa, no. And I'm lucky that I pushed back and said no, because I had no clue what anything was. And it had to be that, yeah, I do have kidney disease, but on top of that, and I did not know I had kidney issues, on top of that, I had an AKI, and that's what plummeted me down and sent me to the ICU. So I got lucky by pushing back and not letting them start me on the dialysis. And knowing that doctor, which I got rid of her shortly after that, and she left the hospital too, they probably wouldn't have watched me for an AKI. I would have been still on dialysis waiting for a transplant to this day, most likely. My life completely different.
That is a wonderful story, James, a terrific story. And, the fact of the matter is that basically shows what the research shows. If people like James don't start, I'm not saying there's never a situation where you have an AKI, where you went from, a 30 down to 5 EGFR, where starting is not reasonable. But in a lot of cases, delaying may be very reasonable, and you may be able to avoid ever having to start. But again, we're doctors. We want to do something. It's like, do something, doc. Do something, doc. You go to a doctor's office, you want the doctor to do something. And that's the nature. It's not a criticism of my colleagues. It's the way we're trained. We're trained to do stuff. We're not trained to wait. We're not trained to sit back and think, well, let me weigh the benefits versus the harms. Unfortunately, that's not the way the world of practice of medicine and the world of the business of medicine. It is a business. It's a massive business.
Yep.
Okay. And as James said, this is a key critical point. If you happen to be in a situation like James and you happen to get started on dialysis, make sure that you ask your doctor, is it possible that my kidneys have recovered? Can you check to see if they have recovered? Okay.
Now, in order to check your kidneys, you still need to be producing urine, correct?
Oh, yeah. If you're not making urine, you're on dialysis. No question. Okay. And this is the biggest issue. As I said, your residual kidney function is golden. It's so important. But you don't have residual kidney function unless you're putting out urine. When I hear about patients that started on dialysis, and let's say their EGFRs are in the 10 plus range or anywhere near that, I ask them, how much urine do you make? If they tell me they're making like a quart, a liter outside the US, we talk about a quart.
Wow, that's a lot.
That's a lot of urine. And my thing to them is go back to your doctor, have your doctor check how much of my own kidney function do I have, because those dialysis machines don't add anything when you've already got your own kidney function. It's been so hard to prove that no matter how fancy the dialysis is, that it's doing anything beyond what your own kidney function is. And producing a liter of urine, that's a lot of kidney function.
Yeah, your kidneys are still working quite well. Or they're still working a bit, enough maybe.
Yeah, I mean, it's not impossible to have trouble with potassium, even if you're making that much urine. I mean, there are lots of reasons that could happen, but like we've talked about, there are medicines to help keep that potassium under control if you've got a willing doctor to work with you and follow you. Okay, you got to be followed. You just can't just disappear and then show up 3 months later, because you may have a problem in between. The last thing I'm going to mention briefly, because we want to get some time for questions, is to go on dialysis, you need a dialysis access. Okay. And James, we'll use you as a guinea pig. we hadn't really talked much about your dialysis access, or has anyone, James?
I never got an access installed.
I know, but
No.
okay. The
Well, they talked
point
about
is,
doing it in my neck, and then they were going to do it in I believe my non-dominant arm is what they were going to do.
exactly. Okay. So, um, we're primarily tonight talking about older folks, and we'll get to younger folks, I'm sure, with the questions, because that's how, last time we got into the dialysis discussion. We happen to have a lot of younger folks that were in that kind of dialysis position. Um, if you are a younger patient, and especially you've got protein in the urine and your kidney function is on the way down, it makes sense, and it might make sense for you, James, although you do not have protein in the urine,
Right.
and you may be one of these people with CKD4. I think you've been in the 15 to 30 range, if I'm not mistaken, for a good while. And there, right? Is that correct?
Yep. I've been sitting in there for years. My last labs had me at 29. I was at 35, and then I started taking, I still have my bottle here, Jardiance, which shot me down to 22. We stopped that. I got up to 25, then 29, and I'll be getting new labs in about 2 weeks to see where I'm at.
Right. So now James is a relatively young fella, and he is in the 30 range. So that's early. But younger folks, when you get into the 20 range, let's say 15 to 20, and you've got protein in the urine, which is not James. Okay, you do not have protein.
Yeah.
So you're lucky. So you may be where you are for another decade or more. Let's hope.
Mm-hmm.
But if you happen to be a younger folk, protein in the urine, you've been losing kidney function steadily, it makes sense to go ahead, as James said, in your non-dominant arm, consider placing an access for hemodialysis. It's just like an insurance for you. In case you get real sick and you need a machine, they don't have to stick catheters in your neck or in your groin. You got something ready there. It's something at least to consider. Older folks, no rush at all. Because like I said, chances are, if you don't let somebody force you on dialysis when you didn't need it, that you likely will die of another cause. But if you do need dialysis, we generally don't like to stick the things in the neck that James was talking about. It's called a central venous catheter. But for an older person, and this is, as I said, I reviewed this paper on people that have multiple illnesses, in addition to kidney disease. They're quite sick. Not unreasonable to put the thing in the neck. They do tend to get infected, and it could be a problem. But like James, don't let them push you into getting a catheter in your neck and starting you on dialysis unnecessarily. I unfortunately had a close friend of mine who was about my age, who was in CKD4 for a while. He probably got sick, went to the hospital. They started him on dialysis. And the poor guy got an infection from the catheter in the neck, and basically it killed him. And in my opinion, he did not even need to start dialysis. So it's a sad, sad situation. And if I can prevent one person from that happening to, I will feel very gratified. Very gratified. So James, I'm going to let you pick out a few questions, and we'll see if we can answer a couple for them, for your audience. Can't hear you.
Sorry, I had to mute on this. It got hot in my office, so I had to open the window, and the birds are out there being so loud, so I kept hitting mute because I kept hearing them echo. We got birds and lots of bees and all the wildlife out in our yard. But there were several questions. Let me find these ones. These were really important. There were people talking about their EGFR. And of course, it's scary because we don't know when to really worry. So I'm gonna bring up several of these. Kathy said her GFR is 79. Want to know if it's good or bad. George is at an 82. Can you talk about GFRs in that range, that above 60, actually quite nearly 80?
Yeah. Okay. So James mentioned GFR and he mentioned eGFR. The E is critical. The E stands for an estimate. Okay. The estimate is primarily determined to just determine it by a lab test, which is called the creatinine. And those of you who have been listening or learning about kidney disease, you know that creatinine is a normal thing that you produce in your body, depending upon how much money you have in your body. It's a normal thing, but it is a marker that we use to determine kidney function. It's just a marker. And we use that creatinine and then we adjust for your age. As you get older, you have less muscle. So if you're my age and you have let's just say I compare me, let's say my creatinine is the same as James, and you're 50. How old are you, James?
I'm 53. I had to think for a second. Like, I don't tell my age ever. As a matter of fact, a quick funny story. A friend of mine, were walking to lunch, and he mentioned his age. And I said, "Hey, I thought you were younger than me." And I actually was like 5 years off on my age. I had to go into Siri and have her tell me how old I was.
Well, that's good. So he's 53, I'm 78, whatever. And we had the same creatinine number and we plugged it into the equation, that's where you get the E, the estimate. His eGFR would be basically, higher than mine, because even though we have the same creatinine, his would be higher. So my GFR would be calculated to be lower because on average I have less muscle mass, older folks. Mm-hmm. So as we said earlier, if you are over 70 and your GFR is over 45, it's probably not even CKD. A lot of labs, because once you get over 60, the eGFR, the estimated kidney function numbers, are highly unreliable, so they don't even report them. So just forget about it. If you're a young person, if you happen to be in your 20s or 30s, having that number may be significant, especially if it comes along with having some protein in the urine. Yeah.
All right, I'm grabbing some questions here. All right, let me go over to this other screen here. All right. Wisconsin Grandma is asking, is it true that if you have kidney disease, stage 3, it could be 10 years before your kidneys are bad enough to be put on dialysis? Can you talk a little bit about how, because there are websites out there that say if your eGFR is this, they give you a timeline before you start dialysis, that based on an eGFR, believe it or not.
Absolutely nonsense. Absolutely nonsense. Those of you who want to know the prediction for whether you'll be on dialysis at all, and I would say, as we've discussed earlier, if you're CKD3, maybe 1 in 1,000 of CKD3s will ever need dialysis. So that's nonsense. There is something called the kidney failure risk equation. All the stuff is in my book. Plug in some of your lab results, gives you an idea about the future. The biggest thing, it's not rocket science. Again, if you are an older person, as we said earlier in tonight's discussion, your EGFR is a risk factor for getting cardiovascular, heart attacks, and that kind of stuff, heart failure. And the likelihood of dying from that cause is extremely high versus dying from kidney failure. And so it is highly unlikely for stage 3, unless you've got massive amounts of protein. Then, of course, it changes the whole game. And, you know, the other big thing besides having lots of protein, controlling your blood pressure. And in today's world, you should have a goal blood pressure of around 120 or less. If you're my age, maybe 130 would be okay. Because a lot of folks of my age are frail. They may fall if they drop their blood pressure too low, and that's another story. But, you know, good blood pressure control, getting your lipids controlled, the protein in the urine, even if you have it, will slow the decline. But on average, very few CKD3 people will ever need dialysis. Very, very unusual.
Yeah, there's no timeline to dialysis, no timeline for years left to live. Yeah, and those just break my heart. Hey, Tanya asked a question. It's a very popular question, one that we did a video about that has over 950,000 views. How do you reduce the protein in the urine? Because we talked about if we can reduce that, we could put the brakes and slow the progression. How do they do that, Doc?
How what now?
Do you reduce protein in your urine?
How does it happen?
No, how do you? So
is that the question?
No, the question is, how do I do it? So what are the drugs? We mentioned it briefly earlier, but Tanya asked, how do you reduce protein in your urine?
The first thing is decreasing protein in your diet is not the way to decrease protein in the urine. Decreasing protein in your diet to levels that are very, very low is not recommended at all. There is at least there has been a very popular book and a popular set of dietary things on Amazon that push very, very low protein diets with supplements they call keto analog supplements. Unnecessary, dangerous, highly dangerous. Don't recommend it. And people say, well, if I got protein in the urine, should I decrease the protein? No, absolutely not. You may probably have to increase protein. You don't want to allow your body proteins to go down, because that in and of itself is a predictor of death. Low body protein levels. There are classes of drugs that can help decrease the urine protein and in turn slow decline of kidney function. And they are the ACEs, the drugs that end in pril, like enalapril. There are the ARBs, the drugs that end in tan, like losartan. And then you have the SGLT2 drugs, the gliflozins, canagliflozins, empagliflozin. Those are really, really good drugs to decrease protein in the urine. The aldosterone antagonists, like spironolactone, are also probably beneficial, but they can raise your potassium. Got to watch that. And there is a very expensive form of that called finerenone, which I personally don't push because it's very expensive, and I would use the class effect of the drug and take a eplerenone or a spironolactone. So those are three classes. And then the GLP-1 drugs, the weight loss drugs, they're being researched now for their effect potentially. There's a little bit of data, and I think will be more. So not only do they decrease your weight, not only do they decrease your cardiovascular risk, but they may slow decline of kidney function. So you're going to have several different types of drugs that could do that. Okay.
All right, DB has an EGFR of 5. BUN is really high at 140, but they feel fine. And they're asking, should they start dialysis?
That's a great question. And first of all, the BUN, okay, the BUN is not a great kidney function test, but it is a good test that your doctor can use in conjunction with your creatinine. So, James, tell me again the number. BUN,
140.
the BUN is what?
140.
And the creatinine is 5?
GFR is 5, creatinine is 11.
Okay. Okay. Well,
And they feel fine. They didn't mention fluid or anything like that.
Right. Well, the high BUN, this gets to be kind of in the woods, and I don't want to get too deep into the weeds, rather. That to me says that there may be something else going on besides your kidneys. If you're not symptomatic with a GFR of 5, if it's really 5, creatinine of 11, you can be managed as long as you're followed at least once a week to make sure your potassium is okay, your fluids are okay, your blood count's okay. It would certainly be reasonable to consider starting dialysis. Now, the fact that your BUN is so high tells me that there may be something going on. You may be breaking down protein. That's one of the reasons, or there may be bleeding going on. There's a lot of potential reasons, so that has to be looked into. But you're in the zone where dialysis should certainly be considered, absolutely. But you're going to have to be followed closely if you're not going to start. And at a minimum, you would want to be educated about your options. You certainly, if you're young enough, you want to get on the transplant list. You qualify. Anyone whose GFR is below 20 in this country, in the U.S., should get on the transplant list. That's your best bet. You want to learn about home dialysis, and I would certainly consider home peritoneal. To me, it is the best option. You don't have to get needles stuck in you. You can do it while you sleep. It's very low tech. So that's the kind of thing that I would do at that level of kidney function.
Yeah. All right. Jen this is a good question. Jen got 2 kidney tests, 2 different ones in the same day. One had an EGFR 47. The other test came back at a 52. Can you talk about why there's 2 different numbers? They both didn't come out the exact same.
They are the same because the number is at least plus or minus 10% to plus or minus 20%. Let's make it simple. 10%. 10% of 50 is 5. So if you're 50, if your number is 45 or 55, it is the same EGFR. EGFR is not an exact thing, and it's easily going to vary by 10% or even 20% from one test to the next. Don't be surprised.
Yeah, I wish they would stop giving an exact number and instead give like an approximate range or something. Because I've seen many people email me and they get their lab and it's 2 points off from the last one and they get depressed. And I try to explain, no, you look at the trend. That's what you need to look at. It's going to go up and down normally, but it's that long-term trend. All right. Now we are at the top of the hour, Doc. Any final comments you want to recommend or advice for someone who is about to start dialysis? Because we talked a lot about it tonight.
Yeah. Well, okay. You want to be sure that you ask for the option of doing it at home. Ask for the option of doing home peritoneal. And try to make sure that you tell your doctor, look, I've still got some residual kidney function. If they get too aggressive about dialyzing people, take off too much fluid too quickly, that can knock off your residual kidney function. So that's the best advice I can give you. It's like, don't let my blood pressure get too low when I'm on the machine. Don't pull off too much fluid so I can keep whatever kidney function I have left. And and try to, do home dialysis, home peritoneal, so you don't have to worry about the access issues and all the needle issues.
Very good. All right, Doc. Thanks so much for your time. I want to mention your book one more time. The book is called Learn the Facts About Kidney Disease. You can get it at Amazon, Barnes & Nobles, any mom and pop bookstore. They would love to order it for you. Swing by. They can look it up in their computers. It's available to everyone. It's also available as an audio book. Super easy to go into Amazon. Get that. Pop it in the car when you're driving around. Dr. Rowe, I have not heard the audio version, but Dr. Rowe said the guy who did it was fantastic. And Dr. Rowe's book is super easy to understand. So you got a great person doing it. Makes it even better. And I encourage everyone to check that out. And I will be back after the long weekend. We got a nice 3-day weekend here. I'll be back on Tuesday, live at 6 p.m. with renal dietitian Jen Hernandez doing an Ask Me Anything, where you can come and ask questions to a renal dietitian. All right, Doc. Thank you so much. It's been fantastic. And I will see all of you in the next video. Bye, everyone.